Everyone. I'm sure we'll have some more people rolling in, but I thought we'd get started with our announcements and to make sure we give Dr. Mello the time to present her. Well, I'm sure it's going to be a really interesting talk. So my name is Dr. Mike Murray. I am the Director of the Division of Autism Services here at the Penn State College of Medicine. And thanks for joining us today. I'll be happy to be the moderator. This seminar series was really created to try and bring together innovative work and explore potential collaborations and provide input into strategic initiatives to support the autism community across Penn State University. In today's seminar, Dr. Catherine Mello will present Evaluating and Improving Service Trajectories for Families and Children with Autism from her work in Quebec, Canada. If you'd like to ask a question during the seminar, please use the Q&A feature, which is on the bottom of your screen here in Zoom. I'll keep track of the questions and relay them to Dr. Mello at the end of the presentation. Today's presentation and all of our seminars are recorded and can be accessed afterwards on the past monthly seminars page on our website. The link will be provided in the chat box in just a moment. If you'd like a certificate of attendance for this seminar, a link for that downloadable certificate will also be provided in the chat box. Just be aware that this link will expire in 1 week, so please download it quickly if you need it. Just a few ASD at PSU reminders before we begin. First, our last ASD at PSU seminar for this academic year will be held virtually on Wednesday, May 5th at noon. The speaker then will be Dr. Catherine Glodowski, who is an assistant professor in the Department of Psychology at Penn State Harrisburg, who will be presenting on an overview of behavioral analytic treatment for restricted and repetitive behavior for individuals with autism. If you are interested in presenting our monthly seminar series for next academic year or have a suggestion for topics, please reach out to us at autismservices@pennstatehealth.psu.edu. Next, we're building an ASD at PSU researchers and stakeholders registry. This registry is hoped to facilitate connections between interested parties and stakeholders around autism training, service, research, and other initiatives. Anyone is welcome to join this registry. To do so, please visit the ASD at PSU Researchers and Stakeholders page, which is on our website. Details will be in the chat box for that as well. And next, please save the date for our virtual symposium, which will be held Wednesday, June 9th from 9 a.m. to 3 p.m. The keynote speaker this year is Dr. Ted Brodkin, which is an associate professor of psychiatry and founder and director of the Adult Autism Spectrum Program at Penn Medicine. He's going to be presenting on social skills for neurotypicals, promoting equity and inclusion for individuals on the spectrum. So should be an interesting talk. Hope you can join us for that. Keep an eye out for our monthly newsletter, which will provide us updates on the symposium and other upcoming ASD at PSU events. If you'd like to receive updates from us, please send an email to autismservices@pennstatehealth.psu.edu to keep track of all that's going on. All right, so now Dr. Mello. So I'm really pleased to introduce Dr. Catherine Mello, who's presenting on evaluating and improving service trajectories for families and children with autism. Dr. Mello is an assistant professor of psychology at Penn State University, Berks. She received her BS in psychology and her MS in experimental psychology from the University of Montreal, and her PhD is in brain and cognitive science from Miami University, which is in Oxford, Ohio. Her scholarly pursuits focus on development and evaluation of assessment tools and intervention programs for children with autism spectrum disorder. Her applied interests include the use of virtual reality and related technologies in research, education, and clinical settings. Dr. Mello has recently published on assessing the feasibility of implementing the Prevent, Treat, Reinforce for Young Children program to address challenging behaviors in children with ASD, developing a questionnaire to evaluate the quality of service trajectories in autism spectrum disorder from families' perspectives, perceptions of early and intensive behavioral intervention services by immigrant families of children with autism, and the feasibility and acceptability of a parent coaching intervention program based on the Early Start Denver model for children with ASD. So a lot of varied interests, which very exciting to hear about. So today, Dr. Mello is going to be discussing evaluating and improving service trajectories for families and children with autism based on her work in Quebec, Canada. Dr. Mello, please, thanks for joining us, and I'm sure everyone is clapping wildly to welcome you to the seminar. Thanks so much for being with us today.
Thank you. It's a delight to be with you, if only virtually today from the periphery of the Berks campus. Today, I'd like to talk about, for instance, the idea of service trajectories conceptually and theoretically. What do we mean by that and how specifically it applies to autism? From there, I'd like to discuss an instrument that my team and I have developed to assess these service trajectories, how we constructed it, how we validated it, and how we're using this instrument and many others as part of a series of pilot initiatives to rethink the service trajectory in Quebec, Canada, which may have some applications beyond our province. So I'll be talking about specifically a pilot clinic for diagnostic evaluation today. But first, I need to acknowledge the many members of my team who could not be here today, several of which have been pioneers in the idea of developing a service trajectory in Quebec, and several of the pilot initiatives that I'll be alluding to today. So I want to take a moment to acknowledge them. These are only some of the researchers that have been involved in the many projects that I'll be summarizing or alluding to today. And so here I am today representing them as a member very much at large of the team and an English speaking ambassador, as it were, as I try to describe first the conceptual basis for some of our work on service trajectories and some of the issues that we've noted in the province of Quebec. I will note that the issues I'm about to describe, you will probably recognize as occurring in various parts throughout the world and probably close to home here in Pennsylvania. So the idea of a care and services trajectory for people with disabilities emerged out of the work of Barelds in the Netherlands, who had been looking at the perspective of service users and families with intellectual disabilities in that area. And they conceived of the care and services trajectory as kind of a dynamic experience, a route, or a sequence that unfolds throughout the individual's lifespan. So this encompasses each of the steps that a person with disabilities takes or their family takes on their behalf as they try to gain access to services to meet their needs. So this will include an experience also of several parallel transitions between services across various stages of their life. It'll also encompass contact with many providers, both in terms of the individuals, but also the organizations or agencies that are involved to meet the needs of that person. In a context of integrated care, this also entails that there be coordination between providers across various tiers of services, so referrals, information sharing, and so forth. And there needs to be a continuity of care and service delivery, even though the services a person receives might be fragmented across multiple organizations that must collaborate with one another. And each individual, of course, requires a variety of supports, so their trajectory is unique and encompasses various domains of life. And one thing that's important here is Barelds and their colleagues investigated how service users and their families experience this trajectory subjectively as well. That is beyond the individual steps taken and objectively the services and providers who are involved. They perceive the quality of this trajectory subjectively, and this quality and this perception is made up of the obstacles and facilitators that they experience at various steps along the way as they navigate it. In the province of Quebec, my team has begun to investigate this idea of trajectory for individuals with autism and their families in the province. So here I'm going to present to you some of the first three phases. The first two I'm breaking up into two subphases. So this trajectory, we could say, begins from the moment where somebody, perhaps a caregiver, a parent, first suspects that a child might be developing atypically. And this trajectory unfolds over a series of steps leading up to here we see school services, but clearly the trajectory extends throughout the entire person's life, including adulthood, work perhaps. They also identified 5 dimensions of this trajectory that together reflect the overall quality of this trajectory. And these were rated as important by parents, and they were more or less well realized in the currently available services. So these dimensions of quality are accessibility, so the ability for the family or the person to obtain the services they need easily and quickly. There's also the idea of continuity. That is, do they experience this trajectory as a series of coherent, continuous steps in an orderly progression? This kind of continuity includes the continuity of relationships with providers, continuity over time, continuity in information sharing, in goals, and in collaboration across domains. So quite a complex aspect of quality. This also encompasses the flexibility of the services themselves. Are they able to adapt and respond to the person's changing needs over time? It also includes the perception of the validity, that is the appropriateness and the applicability of the information and methods that are used, perhaps as a response to the diagnosis itself. And finally, a very important dimension of this concerns the human quality of the trajectory. That is the empathy of providers in terms of the family-provider partnership that emerges, providers' ability to listen and respond to the concerns that the family might be voicing. So these 5 dimensions together make up the perceived quality of the service trajectory. Now, I will begin this trajectory at the beginning. That is when, for a family member or professionals first suspects that the child might be developing atypically. If you're familiar with the Diagnostic Odyssey and Autism paper by Lepe et al., that would be the stage making sense of the child's differences. So these first concerns, once they are acknowledged, launch normally a series of consultations, often beginning with a primary care provider or specialist. Of course, that typically doesn't end there. The family may consult several specialists or several experts, depending on the complexities of the case, as they try to rule out alternatives. This will ultimately culminate into a referral to diagnostic evaluation services. Now, this is a stressful time for families who are at this point observing signs and symptoms in their child, and they may feel that at this stage, their concerns are maybe not being taken seriously. And also, this is a fairly disjointed process, coordinating with all these specialists, so the family is actively taking steps to initiate and make sure that information is being shared between providers to get up to this point. Now, I will also note that at this stage, during these early consultations, families in Quebec are not yet eligible to public services. Every child and family who has autism or intellectual disability will ultimately be entitled to a series of free services like early intervention, respite care, and so forth. But this is only possible once they have received a formal diagnosis of autism. So at this stage of early consultations, the family does not have access to these free public services. They may, however, elect to receive private services for which they pay out of pocket, perhaps consulting with a psychologist, for instance. Now, once that referral has been made to the diagnostic evaluation process, begins an extended and sometimes disjointed evaluation process. At this point, for instance, in the province of Quebec, the assessment will normally follow the guidelines of the Order of Physicians and the Order of Psychologists, which include, for instance, that a multidisciplinary team make the diagnosis. There also needs to be some standardized assessments of intellectual functioning, adaptive behavior, and also a general evaluation of the child's strengths and weaknesses. They must also exercise clinical judgment. Now, this typically happens in the public network of health services in a hospital setting and involves a range of experts and service providers. So for each of these steps, you have to imagine that the family might need to take some action to contact the provider. They may be on a waiting list for a specific evaluation. So again, a lot of delays and also a lot of discontinuity in this phase of the trajectory. And as this is taking place, the family is also still trying to learn more about their child, understand the diagnosis that may follow, and how the system works as a whole. Once the interdisciplinary team will have reached a conclusion, this diagnosis is disclosed to the family. And at this stage, the family may also receive some post-diagnosis support within this system. So there's research showing that the quality of the information provided to the family about the diagnosis, about services and what their options are, and how this information is communicated is really important to how families will experience this phase of their trajectory. As I've said, this is a very stressful period, and we know that parents during this stage of the process can experience symptoms of burnout, depression, and definitely parenting stress. So they may or may not be receiving some supports with respect to this aspect of adjustment when they get their child's diagnosis. They may also receive at this stage some information on how to locate services, that is the public services to which they are now entitled, and maybe some government funding or subsidies that may help them to better care for their child. Or perhaps they will have to take steps to find out about this on their own. So now that we are now in phase 2, the child has received a formal diagnosis of autism, which means they're now entitled to services. The first subphase of this process, I like to call hurry up and wait. Now, families at this stage, when the child was diagnosed, were informed of the importance of early intervention to ensure the child's best prognosis. But at this stage, they find themselves on a waiting list for early intervention, which in the province of Quebec may be up to 2 years. During this stage, they may receive some respite care or other services, And we've seen in the province and elsewhere a blossoming of initiatives of lower cost services that could support families during the waiting period. For instance, parent coaching program with minimal support from an ABA trained therapist to help the parents and the family apply some strategies at home. At the end of this waiting list process, which I can connect to the connecting to services phase in the diagnostic odyssey, the family finally gains access to early intensive behavioral intervention. Now, I say intensive with a caveat because due to the limited resources and increasing demand for autism services in Quebec, the early intervention is not always offered according to optimal, efficacious service delivery parameters. So not always 20 hours per week of one-to-one contact with a therapist, and the duration itself will vary. Now, in the province of Quebec, the mandate is to at least provide every child diagnosed with autism with 1 year of services before they transition to school-based services at age 6. However, I will note that due to the delays in gaining access to diagnosis, and from there, the waiting list for early intervention, some children will age out of eligibility for early intervention before they even receive it. So all in all, I think you can see how we think about this as an odyssey for parents of children with autism. And we know with respect to this that parents are indeed dissatisfied and very overwhelmed by this process. One of the key points of dissatisfaction is, of course, the delays at various stages, receiving the diagnosis and later services. In the UK, these delays, which exist as well, average up to about 3.5 years. In the US, closer to 2 years. And in Canada, our latest estimates are approximately 3 years. And if you're counting up to the receipt of early intervention, this can be a total of 4 years from the first concerns until services begin. And this process is also not satisfactory to parents because it's perceived as complex and discontinuous and lacking in coherence. Parents are taking on the lion's share of the administrative burden. They're on the phone, they're sharing information with providers, and they're trying to self-advocate as well. So we note in the public services a series of challenges that we'd like to tackle. To name a few, we have some accessibility concerns. Again, the system is complex, it is opaque as to its functioning and difficult to navigate. We also have some equity concerns, and this is not just in the province of Quebec. Several researchers have noted racial, ethnic, and socioeconomic disparities and how quickly and how easily families can get a diagnosis for their child and subsequently symptoms. There's also disparities between rural and urban areas in this respect. And we also have concerns about family adjustment and mental health. This period tends to be focused on the assessment for the child, the interventions for the child, but we also need to take into account the family, that is the parents and even siblings, who are experiencing a lot of challenges as they're adjusting to the child's diagnosis. And a very important idea here, as I'm talking about primarily the diagnostic evaluation period, a delayed diagnosis also delays access to public intervention and has long-term implications for the prognosis of the child and their adjustment as they transition in various other stages of their life. So having noted these many challenges, where did we decide to go from there? Upon realizing these issues, well, we set out to tackle 2 major goals in relation to the service trajectories. First, how to measure these trajectories, and second, how to improve them. For the first goal, we determined that we first had to develop a structured instrument. That instrument should help us describe the experiences of families in terms of the time frame, the services, and the actors that are involved in each step of the sequence. That instrument should also help us in identifying obstacles and facilitators that they encounter. We're talking about systemic factors, family factors, and child-related factors, and also as part of this, identifying potential disparities in access to or the quality of the services. And finally, this instrument should help us gather information on families' perceptions, how they perceive the quality of services. And in terms of the second goal, which is a little too large in scope to fully cover today, this goal also comprised evaluating some of our recent and ongoing efforts to address bottlenecks and challenges at various phases of the service trajectory. And ultimately, we'd like to use this information that we're gathering across projects to construct a more systematized model trajectory for families within the public services of Quebec. The goal would be to improve quality for service users while also acknowledging the practical constraints of the public system. With respect to the first goal, I'll start by discussing an instrument that we developed and validated to measure service trajectories in Quebec that we believe could also be adapted to suit different contexts of service delivery. Pennsylvania, perhaps. So I should note to begin that to date, most of the research related to autism trajectories has taken a focused approach, mainly measuring family satisfaction with a specific service or a specific provider. This is useful, but we also need a more comprehensive evaluation of the trajectory as a whole. This evaluation also needs to be contextualized within the current organization of health, social services, and educational services as well. So for us, this instrument should collect information on the structures and processes involved. That is, the actions that are taken by the family, the individuals, and the organizations that they work with, the support and information that they may receive along each step, and how long these steps take, and any gaps or bottlenecks that happen between them. However, we also want to address the perception of quality of this trajectory along the 5 dimensions that I mentioned a little while ago: accessibility, flexibility, continuity, validity, and empathy. This subjectivity is important to us because we're not just interested in objectively measuring the trajectory. Parents are being asked to go through a lot of steps to guarantee the best outcomes for their child at this stage. How they perceive these experiences and the services they receive are going to be critical in their willingness and their capacity to continue investing efforts in the process. And we know that this is also linked to their own well-being, which is an important outcome in its own right. And by extension, this is linked to the well-being and development of their child. So we want to make sure that they are as happy as possible as they go through this. So to construct this instrument, one of the first things we did is review the content of a similar assessment developed in the Netherlands to measure the intellectual disability trajectory in that country. We also consulted some models more generally to evaluate the quality of healthcare and even consumer research more broadly. Also, because we wanted to contextualize the instrument, we also consulted legal and policy documents in Quebec outlining how the trajectory should unfold. And we consulted with service providers and other stakeholders to find out more about how the trajectory usually unfolds. At this stage in the process, we also had a vast body of knowledge of impressions shared by families through interviews and surveys about what they had experienced within public services. This led up to the development of an instrument that we call étude for short, which evaluated version 1, the diagnostic phase of the service trajectory. So this is where we started. We break up this first phase of diagnostic evaluation into phases 1A and 1B. So phase 1A, again, beginning with the first concerns about atypical development, and phase 1B beginning when the diagnostic evaluation proper begins and ending when that diagnosis is shared with the family. For each of these 2 phases, we constructed a series of descriptive items to collect information about structures, processes, timelines, agents involved, some multiple choice and some open-ended. And we also included the subjective quality ratings, 19 items representing the 5 dimensions for each of these subphases. I'll show you an example of these few items here. So when participants who are answering this survey reach this part, the quality assessment, they have already described the various providers they've interacted with over time and the services they've received. And now they're being asked to reflect globally across all these services. Were the service providers and professionals that they met available throughout all of these steps? So that would be assessing the dimension of accessibility. Were they effectively sharing information about the child and the family? This assesses continuity, specifically the continuity of information. And could these providers adjust to the needs of the child and the family over time? Flexibility. And did they inform the family clearly about what they had to do to access assessment services? This is the validity dimension. And finally, were these providers essentially empathetic? Did they listen to the family's concerns about the child's development and needs? So these are just some examples of the quality assessment items that the family is being asked to reflect on globally about this phase of the trajectory. So to validate this instrument, we first looked at a preliminary version that we developed in French, and we pre-tested it with 2 families who talked aloud with research assistants so we could clarify some of the items. We also had the instrument reviewed by an expert, a psychologist not affiliated with a research team, but who knows these challenges well. And finally, we translated this instrument into English with 2 independent English-speaking translators who were professionals in the field, and the final English translation was also pilot tested with the family. So following a few minor revisions to the contents, we were ready to validate the instrument proper. Our validation sample consisted of 200 families whose child had recently been diagnosed with autism and or intellectual disability within the services. Specifically, our main validation sample were 183 families who had gotten their diagnosis through a pilot clinic that I'll talk about in more detail later. But we also had 17 families who were recruited from the public healthcare network, so they had received a diagnosis in a hospital following the process that I described a little bit earlier as part of the Odyssey. We also queried research assistants about their experiences administering this measure, and we also shared it with various representatives of the service providers and the public network as a whole to get their insights on it. And with the validation sample, we also administered 2 concurrent measures. One is the client satisfaction questionnaire, which is one of these more focused customer satisfaction type measures that was specifically for them about the pilot clinic where they had received their diagnosis. Something we believe should converge with the evaluation of that phase of their service trajectory specifically. We also administered another outcome that we tend to use in program evaluation to get an assessment of the family's overall well-being. This is a distinct construct than a perception of the quality of the service trajectory, but they should be conceptually related. Now here you have to imagine that I had many slides with many tables and graphs that I was very excited to share with you, but feel free to contact me for more. Here's, I think, what you need to know in a nutshell. Our factor analyses indicated that the structure of the instrument was indeed consistent with the 5 dimensions of quality that I've talked about, but it also suggested the existence of a global higher order construct of quality more generally that encompasses these 5 dimensions. So it makes sense to also talk about globally quality. The instrument itself and the 2 subphases that we're assessing separately all showed high internal consistency. And we also noted that the assessment of the quality of specifically the diagnostic evaluation phase, so 1B, converged with parents' ratings of their satisfaction with the clinic that for them had delivered this evaluation. So this is a good indication of converging validity of the instrument. We also know that it is distinct, as expected, but conceptually related to family quality of life. That is, we noted that the first phase of the diagnostic evaluation, those early concerns, were slightly linked to family quality of life, specifically the family's perceptions of disability support and their emotional well-being, which makes sense in the context of the literature of how families are affected during this phase of their diagnostic trajectory. We also noted that the instrument was sensitive to differences in service delivery models. That is, we compared the assessments of the group who had received their diagnosis in the pilot clinic to those who had received it in the public network of services as usual. For phase 1A, that is the early concerns and early consultations, which was the same for all families, there were no differences in their evaluations of quality. However, for phase 1B, which was streamlined in the pilot clinic for one group and not so much, we do note that indeed there is a difference in how they perceive the quality of their services. So excellent sensitivity to different service delivery models. And finally, we note that the instrument had very good face validity for all stakeholders. Parents said that the items were clear and easy to understand, and specifically, they felt that it was relevant to the experiences they had had. They commented that, yes, they were satisfied with the pilot clinic, but the journey they had taken to get there in the first place had been challenging, and they were appreciating the opportunity to speak to that part of their experiences through the instrument ETAP. We also consulted some service providers and members of the government associated with this branch of the public services, and they all said that the instrument provided a common language to speak to some of the issues that exist in the system, and also made it easier to identify potential targets for improvement. Having described one of the many tools that we use in evaluating and thinking about service trajectories, I'd like to present one of several ongoing or recent pilot initiatives that have been happening throughout the province with my team. But first, maybe some general context to this pilot work. So the ultimate goal of this area of the team's research agenda is to propose a new model trajectory, a model route for public services for autism and intellectual disability in the province. Lofty goal indeed. Specifically within the context of early childhood services, this means that we have to rethink our approach to screening and diagnosing autism, also intellectual disability, what happens after the diagnosis when the family is in a waiting period for interventions, and what kind of services that we can provide alongside before, during, or after early intensive intervention to facilitate the well-being of the entire family. So starting with parents' first concerns, this means that we need to tackle some challenges such as a series of bottlenecks that introduce extensive delays, the complexity of the system itself, the series of steps and procedures that can be sometimes difficult to understand for families and require a lot of time and effort from them. We also need to ensure that we leverage the expertise of professionals, follow best practices, and reach accurate diagnoses. This can seem at odds with the strategies that we might take in relation to the first 2 points, which speak to increasing the efficiency of the system, but bear with me. And also, we want to find out how to better orient family towards services and facilitate their navigation of the system after a diagnosis. And throughout, we would also like to promote the satisfaction and well-being of parents and the family as a whole. All this is done in keeping with the overarching values of the public system, which are accessibility and equity in service delivery. So today I want to talk about one such initiative. This one is a collaboration between public services and a public charitable foundation. They partnered together to assemble a pilot clinic that would help diagnose children with developmental disabilities. So the clinical model was intended to improve the public system's ability to diagnose developmental disabilities according to best practices, but also taking into account the challenges that I just listed. So in contrast to the current situation within the hospital system, this would exist as a centralized place for all elements of the assessment process, following a referral from primary care providers, for instance. The major goal of this clinic was to address the existing waiting lists. So due to the bottlenecks that I've described previously, in the urban area of Montreal alone, there were 700 children who were on waiting list for diagnostic evaluation at the time that the clinic started. And some of these children had been on the waiting list for 3 years. Having addressed these bottlenecks and hopefully made a dent into the extensive waiting lists, the clinic should, for all families, decrease waiting times for diagnosis and, by extension, for intervention. The goal of the clinic was actually to have the entire diagnostic evaluation from referral to the final disclosure of the diagnosis happen under 3 months, if at all possible. And for this to happen, of course, the clinic would have to collaborate with existing services, so the referring bodies, but also the intervention providers and the government as a whole. In a nutshell, here is the assessment process as it took place at the clinic and the kind of services that it was offering. This may seem somewhat familiar. So, of course, there were standardized assessments such as an interview and an observation for the symptoms of autism, but also an assessment of intellectual functioning and adaptive behavior. Every child will also receive a medical examination. Now, depending on the symptomology of the child and their needs, there may also be an observation at school, preschool, or daycare by either an applied behavior analyst or a psychologist, and if needed, some consultations with a speech-language pathologist or an occupational therapist. As per the guidelines and best practices in Quebec, the diagnostic evaluation as a whole would involve a multidisciplinary team, and they would have interdisciplinary conferences where they would discuss each case. Once the team had decided on a diagnosis, they would meet with the family to share this information and also provide a written report to the family that they could also take to their daycare. An important component of the services is the concept of a family support coordinator who was there with the family throughout the entire assessment, but also did the post-diagnostic follow-up. So after the diagnosis was made, this coordinator would reach out to the family and, for instance, share with them information on how they could apply for public services, maybe how to fill out forms to get subsidies for different aspects of care. And finally, another step that was implemented as part of the clinic were the presence of parent support groups that were facilitated by the clinic itself. Now, our team was fortunate to partner with this clinic to evaluate its implementation and learn valuable information about the families it served. So one of our goals was to evaluate specifically the degree to which the clinic was able to implement its clinical model with fidelity. So this was based on a series of implementation indicators that we had developed in advance with them. And through this process, we wanted to also identify some of the obstacles and facilitators to implementing this clinical model to reach the goals that I've just outlined. We also wanted to take this opportunity to document children's clinical profile at the time of the diagnosis and also capture the characteristics of the families and what they had experienced at their trajectory to date when they arrived at the clinic. Another goal that we had was to evaluate the social validity of this clinic and this process from the perspective of the parents. Were they satisfied? Did they perceive it as effective and helping them along the way? And finally, still ongoing, we wanted to follow up longitudinally with families to find out more about what they experience in the later phases of their trajectory on a year-to-year basis. So first, let's take a look at some of the implementation indicators. This data was gathered during the first year, but continued thereafter. There were 5 general areas of implementation fidelity that we wanted to investigate. The fidelity of the referral process. So that is how our partners in the community hospital settings, community health centers referred families to the diagnostic clinic. So they had to identify eligible families. First of all, discuss the possible transfer with the family and obtain their consent so that the files could be digitally transferred to the clinic. We also wanted to evaluate the fidelity of the assessment process, of the organization's ability to staff all required positions to implement its clinical model, how the team functioned in these assessments, and the venue itself. So I'm just going to go over a few of the obstacles and facilitators that we observed along the way. A great facilitator to the referral process was the ability to communicate effectively with the partner organizations within the public services. However, these referring bodies noted some points of dissatisfaction. For instance, they found that the admission criteria for this clinic were a little bit restrictive. They were limited to children under the age of 5, and also families had to speak fluently either English or French to participate in the process. And the referrers also felt like they lacked the time and resources sometimes to complete the referral process as indicated. In terms of assessment, the team found that this was greatly facilitated by being encouraged to follow best practices outlined for the province, having access to qualified staff who collaborated well with each other and with families. Where this was a little bit more difficult to implement was in the case of complex clinical profiles. And in particular, they noted that the guidelines to assess intellectual disability in the province were not as clear as those for autism. So that was one of the hurdles that was noted. At the organizational level, no clear facilitators emerged, but some of the obstacles were that staff sometimes felt like they lacked the time, the training, or the supervision to carry out the roles as intended. And sometimes the definition of each member's role within the team was not as clear as it could be. The team noted as a facilitator to doing the work the fact that they could communicate well with one another and share their distinct expertise as part of this diagnostic process, and that they could do that with mutual respect. But, and this is starting to look like a common theme, the team members felt like they sometimes lacked the time to coordinate and communicate as effectively as they had wished. The venue overall was a really strong point of the clinic, and this was important to us. So the clinic was in a centralized location in the city of Montreal, easily accessible by public transit. This, however, meant that there were fewer parking spaces for those who wanted to drive there. And also, the team felt like they wanted more space and more materials to assess the volume of children who were coming in for a diagnosis. So potential areas of improvement there. Now, I'll give you a little bit of a snapshot of the families who went through this diagnostic clinic. I will say that this represents less than a quarter of all the families who received a diagnosis in the 4 years that the clinic was up and running. We recruited them only at the end of the clinical process during a post-diagnosis follow-up with a support coordinator. Said, hey, would you like to be part of a longitudinal study on your experiences, which is a big ask. So this sample may not be representative of everyone who went through the clinic, but with that caveat in mind, let me tell you a few things about them. Well, first of all, as you can see, the majority of children who were diagnosed at the clinic received a diagnosis of autism and or intellectual disability, which makes sense given the specialization of the clinic. Speaking about parents, I'll note a couple of salient characteristics for me. One of them is income. Compared to the surrounding urban area, they had a much lower income on average. In fact, approximately half of the sample would qualify as living below the poverty line for the area. However, they tended to have a relatively high degree of education. So more than half of the sample, both parents, so mother and father, had a college degree or higher. And less than a third of our participants had been born in Canada. So clearly, Montreal is a very diverse area with a lot of residents having immigrated there. However, this is still more diverse than the community at large. What's important to note is that the characteristics of these participants represent the people who have been on waiting lists for a diagnosis for autism the longest. So maybe the more underserved members of the community who maybe were not able to use private services or make use of a better understanding of the system in the province for having lived there longer to navigate it more efficiently. Almost all the children were enrolled in daycare at the time of the study. And as you might expect, most of them were boys. So let's talk about some of their early concerns that were noted at which launched the diagnostic trajectory. So most often, the first concerns about the child's development came from a family member, though about a third came from someone outside the family for the first time. The concerns were usually noted specifically by the mother. However, we note that the second person most likely to recommend that further evaluation was the daycare staff for these children, but also sometimes primary care physicians or maybe the nurse who was delivering immunization. The topic of the first concerns about the child's development was most often language, although sometimes also motor or social development. The first person they consulted tended to be their pediatrician, but sometimes also other specialists. And I'll also note, and this is an important point, which goes into the issues of accessibility that I've discussed before. Fewer than a quarter of the participants in this study had received any kind of services for autism prior to their child being diagnosed. So again, these would have been private services. So these would be mostly those who did receive them or at one time on-demand consultation, for instance, with a speech-language pathologist. A couple of highlights from the timeline of their service trajectory. Children on average were aged about 22 months at the time where the parent expressed their first concern. They waited on average a little less than 3 months to have that first consultation, again, typically with a pediatrician. At the time of their diagnosis, at the end of this part of the process, children were aged on average 4 years, so 48 months. So this means that there was about 26 months that elapsed between the time a family member or caregiver first had some concerns about the child's development to that formal diagnostic label that would give them access to public services. And on average, the families consulted about 3 providers prior to being referred for diagnostic evaluation and another 3.5 during the assessment process itself. The goal of the clinic here was to have at least 4 different professionals involved in the assessment, so that's not quite the number we were aiming for. A lot of numbers here, just going to give you some highlights about the perceived quality of services broken down by phase and holistically. We note clearly that there's a higher evaluation of phase 1B, the assessment, which makes sense because the clinic was developed with the goal of facilitating the quality of this process, as compared to what happened in phase 1A, which was public system, as usual, disjointed series of referrals, bottlenecks. And we noted that there was a strong evaluation for the clinic overall, but in particular, the empathy of providers and the continuity of care that was provided at the clinic. We noted a few factors associated with perceived quality in different dimensions. So I'll break them down in terms of systemic, family, and child related. As one might expect, families perceived a lower quality of their trajectory if this trajectory took longer from the first concerns to the diagnosis, and if they had to consult more people along the way. However, kind of counterintuitively, families whose child was older at the time of diagnosis tended to rate the empathy of the process higher. And they also felt like the higher validity of their trajectory if they had been given clear information about autism at some point in this process. In terms of characteristics of family, we noted that the families who spoke French at home tended to rate greater empathy in providers. So that may speak to a language bias in the representation of staff, for instance. Families where the parents had immigrated to Canada tended to be less satisfied. They generally evaluated the diagnostic evaluation phase lower. And we noted an inverse relation between household income and the perceived quality of the process. This may be because families who had a higher income may have had other options and thus had higher expectations for what the clinic should be offering them. And finally, in terms of child factors, we note that children having received a dual diagnosis of autism and intellectual disability, their parents perceived the trajectory to have had less flexibility. I'm running a little bit short on time, and I see that we're going to move into Q&A. So let me wrap this up very quickly with a little bit more information on parents' satisfaction with the clinic. Well, overall, this was a positive experience for them, though they felt like it maybe didn't have quite the impact on their family's quality of life. And they were satisfied with some key features of the clinic. For instance, let's talk about what they were less satisfied. They felt like they were less satisfied with the aspect of the clinic that was related to interventions. That is, they felt like they could have received clearer explanations of the interventions available to the child. And what was the highest point of dissatisfaction is that the clinic could not guarantee to families that they would subsequently access early intervention and access it quickly. That was unfortunately not something they could guarantee. However, they did rate highly and were very satisfied with the welcoming atmosphere of the clinic and the respect that they received from the staff. So a couple of strong suits of the clinic based on parents' testimonials. They liked that they were able to get a diagnosis quickly. On average, that took 3.9 months, so a little over the target 3 months, especially for complex clinical profiles, but still. And they appreciated the delivery and the format of the diagnostic report. So the way the information was communicated to them in writing and orally. And they felt like the clinic did a good job of facilitating their access to interventions and funding, like helping explain that process to them, and that somebody at the clinic followed up with them every step along the way, even after the diagnosis, and that throughout they felt like they were receiving psychosocial support. They felt less isolated in this stage of their trajectory. Some of the factors that we observed that were related with satisfaction, and you'll see some connections with the overall ratings of quality. Families who had higher income may have had higher expectations for the information that the clinic could deliver. We noted some associations between parent stress and how satisfied they were with staff. Mothers who were more stressed tended to perceive the staff more favorably, perhaps because they were most closely involved with the clinic and thus were more likely to receive direct support from the staff. Whereas fathers in general tend to be a little more peripheral to this complex process. So if they were experiencing higher levels of stress, they may have felt this as an unmet need because they didn't have that kind of contact with the clinic. We did note also that families tended to be a little less satisfied with the information received if their child got a diagnosis other than autism or intellectual disability, and families whose child had a dual diagnosis were a little less satisfied with the staff.